Yes, ma'am. Yes, ma'am.
Good morning, ma'am.
Yeah. All the best.
Thank you, ma'am.
Okay, Shafila and Nikita.
Yes, ma'am.
Okay, start presentation.
Yes, ma'am. I'll share my screen. Ma'am.
Who is presenting?
I'm presenting, ma'am. I'm just sharing my screen.
Okay, ma. Shafila. Okay, you are presenting. Okay.
Yes, ma'am.
Nikita.
Ma'am, is my screen visible?
Yes, ma. Your screen is visible. Go ahead.
Good morning, everyone. Today is my case presentation on RPL. Mrs. X, 28 years, wife of Mr. Y, age 33 years. She is gravida for abortion 3, referred from nearby primary health center as a case of recurrent pregnancy loss with history of 2 months of amenorrhea. She is a housewife hailing from Kadalur, educated up to class 12, belonging to low socioeconomic status. History of presenting illness. There is no history of excessive nausea or vomiting. There is no history of bleeding or spotting per vaginum. No history of burning, micturition, or any white discharge. No history of fever with rashes. No history of...
Wait. When you're presenting a case, always I tell the postgraduates, there is no need of going into the so many negative histories. Okay, ma? Any case for the matter you take for the exam, your time will be very less. 15 minutes time you will have for each of you, one of you in the exams, final exams. Okay.
Yes,
and you go on presenting like this, you know, now my attention goes off from here. So many negative points which is not relevant. Okay. Why do you want to know secretion from the breast, radiation exposure? If there is radiation exposure and she is infertile, she will be okay.
Yes, ma'am.
She will not become pregnant now. Anyway, they would have told even a recent radiation exposure, they would have told.
Okay.
So, please. So don't go in for negative histories like this. See, go to the first slide. She has become 2 months of amenorrhea, that's all. Here, what is very pertinent to us in the 2 months of amenorrhea history? What is the pertinent history in the 2 months of amenorrhea?
We have to confirm the pregnancy, ma'am.
She has come with the confirmation because she is referred to you, is it not? The confirmation would have been done. 2 months of amenorrhea, what history is important? What history is reliable for us here?
First trimester history, ma'am.
Bleeding, is it?
Bleeding or spotting
First
PV.
trimester bleeding is important. One more thing may not be relevant to this case, but what is important is excess vomiting.
Vomiting.
These are the two things which is for us here. What is most important is it's a bleeding.
Yes.
Why do we think the bleeding is important?
Because she has already.
It can happen where? Which are the period of the gestation where the RPL can be there?
It can be in first trimester, ma'am. That can be less than 10 weeks.
No, I'll tell you. Pre-implantation failure.
Pre-implantation.
Okay. Pre-embryonic failure. That means in these two conditions, patient will get her periods.
Okay, ma'am.
We won't be knowing it, is it not?
Yes,
she says 2 days was, madam, 2 to 3 days extra, but I got the bleeding. Somebody says, madam, it was faintly positive when I did just 3 days. She's 3 days post her period date and 3 days faintly positive, madam, but I got my period. That is what that goes for pre-embryonic. Implantation failure, we don't be knowing. Implantation failures, why the bleeding has come? Because, can somebody mute, please? Before she gets the period, is it not? That can be known only in the IVF pregnancies.
Yes, ma'am. Recurrent implantation failure.
There in IVF pregnancies?
Yes, ma'am. Recurrent implantation
failure. Now
failure.
you tell me, what are all the cases which are included in the recurrent pregnancy loss? What are the cases which are not included in the recurrent pregnancy loss?
Ma'am, 2 or more clinical criteria for recurrent pregnancy loss.
That is the definition. 2 or more pregnancy losses is taken at 3. Somebody, only RCOG sticks on even to 3 pregnancy losses.
Yes, ma'am.
But all other
guidelines are 2 or more pregnancy losses, ma'am.
Okay, Asia and ACOG, everybody says it's 2 or more pregnancy losses. At least you have to start investigating them, right?
Yes, ma'am.
Okay. So now tell me, I asked you one question. What are all the pregnancy losses included into RPL? Which are the ones which are not included into RPL definition?
Ma'am, except ectopic, molar pregnancy and
biochemical pregnancy.
Molar and implantation failures, we won't be knowing it, is it not?
Yes, ma'am.
Except that all other, that means Pregnancy of unknown location. You have a beta HCG positive, but you didn't get the pregnancy anywhere. Repeatedly it happens. That also included 2 or more times. Okay. Biochemical pregnancy. What do you mean by biochemical pregnancy?
Beta HCG is elevated, but on ultrasound, no gestational sac.
No
evidence
gestational sac. Amenorrhea not more than 1 week. Is it not? And there is a slight rise in beta HCG. That's called biochemical pregnancy. 2 or 3 biochemical pregnancy losses also will come into RPL. Is it not?
Yes, ma'am.
So all those things. That's why 2 months of amenorrhea, that means it is embryonic loss. It is not the pre-embryonic, it is not implantation failure. So we can take implantation failures, pre-embryonic pregnancy loss, embryonic pregnancy loss, that is early pregnancy. And after 12 weeks also, we have the pregnancy losses. Until what gestation you include into the definition of RPL?
10 weeks.
20 weeks. 20 weeks.
24 weeks.
24 weeks. Sorry, ma'am. 24 weeks.
24 weeks. Okay, ma'am. Go ahead. Next slide. Yeah. So all this no is not important for us.
Okay.
Okay.
Menstrual history, menarche, she attained menarche at 14 years. Previous cycles were regular, ma'am, with average flow. LMP was 26/12/2021 and EDD is 2/10/2022. Gestational age is 8 weeks, 5 days.
Okay, she comes to you with the 8 weeks and 5 days of gestation. She's very anxious because she has lost the 3.
Already 3.
And you are the new person and you are in a medical college. She thinks that you will save her. Now she will ask you, madam, can you give me guarantee that I will continue this pregnancy? What's your answer? And how can you give fairly? It's okay, you may. What is your answer?
We cannot give a 100% guarantee, ma'am, but we will try and intervene as much as possible. We will try and do all the investigation.
Yes, I will tell you. So at this juncture, okay, what findings in the ultrasound will tell you it's going to be a viable pregnancy or it's not going to be a viable pregnancy?
At this juncture, ma'am,
Dr. Shashi, whenever you want to take over, please tell me and you can take over.
No problem, madam. You carry on, madam.
No, please, you also have to be, no, you are the faculty. Yes, dear. Tell me, what are the ultrasound findings which will tell you that this pregnancy is viable? Yes, we can. See, once she passes the first trimester, you can give 50% of guarantee for her, right?
Yes, ma'am.
We may not guarantee for the problems she is going to encounter, like preeclampsia and then IFGR and abruption. All that we cannot predict. But at least pregnancy can continue once she passes the 12th week of pregnancy. Is it not? Now she's 8 weeks. She is very anxious. She asks you, what is your answer?
On ultrasound, if there is a gestational sac of more than 25 mm, if the CRL is more than 7 mm, and if there is a cardiac.
What do you mean by that? Gestational sac more than 25 mm? It corresponds. Suppose she has come at 6 weeks of pregnancy, 6 or 6.5 weeks.
With no yolk, with no
yolk sac. No yolk sac.
Say that.
Yes, ma'am.
Say that. Yes.
CRL is 7 mm, and if there is no cardiac activity, ma'am, then it is not a viable pregnancy.
So that is a delay in appearing of the gestational
sac.
And fetal heart is one of the concerns for us. Position of the gestational sac, where it is situated. Yes, where should be the gestational sac usually? Eccentric or centric?
In one corner. Eccentric.
So if it is low in the cavity, it's a center.
Yes,
okay, that also gives. And the delay in appearing of all these things, what you said, yolk sac, fetal node, fetal heart, and fetal bradycardia. That's very, very important. Fetal heart is there, but I had one or two. When they asked, I said, okay, I'll keep my fingers crossed. Let's see next week. Bradycardia.
Less than 100.
Less than 100.
You know what? One more thing. What IVF specialist will do. They start even before embryo transfer, they do uterine artery Doppler. There is increased PI of the uterine artery at 7 weeks.
Yes, ma'am.
Definitely it's going to be. So you have to start in such places very early heparin. Okay, we'll come to that when we go to the Apla syndrome. So these are the things. Okay, and the Doppler, the vascularity. You see all these things to say that most probably this pregnancy is viable or this pregnancy is not viable. So once all the characters of viability are there, there is no subchorionic bleed. Okay. When all these things are there, you will tell the patient, yeah, probably you will continue, but we'll wait until 12th week. Okay. Okay, go ahead.
Marital history, she's been married for 4 years. It was a non-consanguineous marriage.
So you have to do evaluating this patient at the first trimester before 12th week also. These are all the things you have to note down when a RPL patient comes to you. That's point number 1. Please remember, because I may not sum up at the end for you people as madam was asking me. But this is one point at the first trimester when we come for the diagnosis or a, what do you call it, gestational age, whatever you do first scan. These are the things especially you see in a case of RPL and note down. Okay, next. Yes, ma'am.
Moving on to the obstetric history, ma'am. Her first pregnancy, she conceived 2 months after marriage. It was a spontaneous conception. She confirmed pregnancy by urine pregnancy test as 50 days of amenorrhea at home. Patient was not booked outside and ultrasound was not done. Patient gives history of hyperemesis and she gives history of spontaneous onset of bleeding 10 days after the urine pregnancy test, followed by expulsion of product of conception. Patient had gone to the nearby PHC. A check ultrasound was done and uterine cavity was found to be empty.
Okay.
In the second pregnancy, she conceived after 6 months after the first pregnancy. UPT was done at 45 days of amenorrhea. She was booked at a nearby PHC and folic acid was given. Ultrasound was done at 9 weeks gestational age, corresponding a single live intrauterine gestation with cardiac activity was noted, and there is history of hyperemesis. Patient gave a similar history of spontaneous bleeding followed by expulsion of product of conception at home at 11 weeks gestation. Check ultrasound showed an empty uterine cavity. At this stage, the patient was evaluated with glucose tolerance test and thyroid profile, and the reports were normal.
Can you comment on this thyroid profile and GTT? Say many bodies will not recommend this also. If you take RCOG, they don't even say all these things to be done. Okay. Can you just say GTT and thyroid profile? Yes. Just quick comment on that.
Yes, ma'am. And impaired glucose tolerance, if the patient is diabetic and if it is uncontrolled diabetic, there is a high chance of recurrent pregnancy loss, because hyperglycemia is directly embryotoxic. And thyroid profile, if the TSH is more than 2.5, then according to the new guideline, we have to do thyroid peroxidase antibody. And if that is positive, that will also cause autoimmune inflammatory reaction, and it can.
No. Thyroid antibodies, if they are positive, do you think that what does it indicate?
It is like an
yes, you are right. What does it indicate? It indicates that she has some
autoimmune disorder.
Yes. That doesn't mean that when the thyroid antibodies are positive, there is no need that you have a hypothyroidism, right?
No,
her thyroid profile may be normal.
No, ma'am. It could be normal. Yes, ma'am.
Normal. And when there is a hypothyroidism, okay, subclinical hypothyroidism, overt hypothyroidism, what is the effect on this recurrent pregnancy loss?
The overt hypothyroidism has more chance of causing recurrent pregnancy.
Is it not? If she is a hypothyroid and it is not under control, it may cause pregnancy loss due to what? Due to what?
It causes direct effect on the trophoblast, ma'am. The syncytial the trophoblastic proliferation and angiogenesis, and there will be recurrent that can cause recurrent pregnancy.
It's a luteal phase defect it will cause.
Luteal phase defect. No?
Luteal phase defect it will cause. If there's a hypothyroidism, it causes luteal phase defect. That's a way. Otherwise, thyroid per se has not, especially if there's an overt hypothyroidism, what will be the effect on the fertility for this lady? It is infertility rather than the pregnancy loss, is it not? If it is subclinical hypothyroidism, which we have not diagnosed, it may not have really the effect, but still, if we think it may be because it causes the luteal phase defect, is it not? Okay, that is the way where we stand about this. How overt hypothyroidism, they could have diagnosed it because she comes with the symptoms and all, is it not?
Yes.
Okay, go ahead, next.
The third pregnancy, she had conceived spontaneously 8 months after the second pregnancy. UPT was done at 52 days of amenorrhea. Folic acid was taken. Ultrasound was done at 10 weeks gestation. It showed a single live gestation with good cardiac activity, and patient was advised to take micronized progesterone. No history of intake of low dose aspirin. This was followed by spontaneous onset of bleeding, and ultrasound revealed incomplete abortion. Dilatation and curettage was done at with a private practitioner, and product was not sent for cytogenetic study. After the third miscarriage, patient was evaluated for antiphospholipid antibodies and was found positive for.
What do you think? What you should have done it in this case? Okay, she comes with abortions. Why directly you have gone in for APLA workup? What is the first thing you have to think of?
First thing we have to think of the general condition of the patient, ma'am, whether she is obese or lean, extreme weight, then smoking, alcohol consumption, any abuse. After that, we have to.
Yeah, those are good. Yes, these
Yes,
are
ma'am.
the
After that, we have to.
contributing factors. Yes. Now, what is
Yes,
the
ma'am.
other thing? What you have to think? First,
We have to rule
investigation
out.
when there is
We have to
early
rule out
pregnancy loss.
Anatomical defects, ma'am. We
Boy, come
structural.
on. I tell you, anatomical defect. Every woman, she would have had lot of ultrasounds done. If nothing else, even she doesn't come to the doctor also, she would have had ultrasounds. Is it not?
Yes,
that's a trend now. So any time when they have done 3 pregnancy losses, don't you think they could have found out anatomical defects?
Yes, ma'am. They could have.
Is it not?
Yes, ma'am.
Okay. When you think of anatomical defects in the early pregnancy loss, which anatomical defect will cause, like this is in the first trimester loss, which anatomical defect would have caused this?
Septate, ma'am. More septate uterus.
Septate uterus could have caused early pregnancy loss because it gave an implantation onto the septum where there is no vascular supply. Is it not? What are the other anatomical defects which could cause the pregnancy loss?
Bicornuate uterus, ma'am.
Do you think really bicornuate uterus is a cause for RPL?
No, ma'am.
What can happen in bicornuate uterus? What problem will have with pregnancy in a bicornuate uterus?
Implantation. I mean, there will be less space for the fetus to.
So it will be preterm labor.
Preterm labor.
Abnormal presentations. Is it not? Preterm labor is common in a bicornuate. Okay,
Ma'am,
bicornuate may not be a RPL. Septate, yes, definitely. What is the other one which can cause this?
Didelphys.
Didelphys will not. Because what happens is one horn where pregnancy it grows. That's why they
about unicornuate
uterus.
Yes, unicornuate uterus can have a problem. In a unicornuate uterus, what is an additional precaution you will take when there is a pregnancy? Patient comes with a recurrent, even if there is no recurrent pregnancy loss also. What is the one you do it? It is recommended, in fact.
Cervical length.
Prophylactic cerclage.
Cerclage.
Prophylactic cerclage, you put it off before itself so that you know that it's a unicornuate. This cannot grow very much. It has a limited capacity to grow, is it not? So yes, the septate uterus is very, very important for us. Okay. Here itself, what is the role of hysteroscopy in RPL?
Hysteroscopy can help us find out if there is any uterine anomaly, ma'am. Also, in other acquired conditions like if there is Asherman syndrome or if...
Do you think Asherman syndrome they will conceive?
No, ma'am.
No, ma'am.
It will be the cavity will be obliterated.
Okay, then see, there is something said that
there are polyps.
Polyps, now the infertility specialists, what they do, they the scraping of the endometrium they do, because the polyps, they say polyps are there, so that probably these polyps are causing the failure of recurrent pregnancy loss they do. But many bodies, especially Escher and all, they don't agree for this. Okay, unnecessarily we don't. Especially, it is very important hysteroscopy when we have septate uterus to diagnose as well as to do the resection of the septum. That's a one place where uterine anomalies need a treatment for in a recurrent pregnancy loss is septate uterus. We don't need to touch didelphys. We don't need to touch the bicornuate, unicornuate. You can't do anything for that except but praying and patient. Okay, so this is one thing in anatomical defects we have to think of. Is it not? It's a septate uterus. You would have known by ultrasound. How will you know? Just when you are doing routine ultrasound, how will you know it's a septate uterus?
T-shaped.
No, ma'am. There will be a septum in between. Sorry. There will be the uterine cavity will be, there will be a septum that is in between the two.
No, you can't be seeing the septum. You can see the two, the echoes can be there. Yes, bicornuate, how will you know? See, bicornuate and septate, it is very difficult to know by ultrasound, is it not? It could be either by MRI or by hysteroscopy. How will you know? What is the feature it will have?
The angle will
transverse diameter is more than the vertical of the uterus, is it not? Yes, and in the bicornuate, you see two endometrial echoes will be there. Okay. Yes. Okay, so that's a one thing you, when it is there like that, you have to rule out whether it's a septate or it is a bicornuate uterus. For that, best could be either you go for 3D ultrasound. Now you don't even need to go to MRI. 3D ultrasound will tell us that. Otherwise, anyway, hysteroscopy you can do both for diagnostic as well as the therapeutic purpose in the case of RPL. Not
Okay.
able to hear properly. Is it only for me? Somebody is putting it as. Am I audible?
Yes, ma'am, you are audible, ma'am.
Okay, okay. So that's it about the anatomical defects, what we have. About 3 to 5% of the RPLs could be anatomical. But I tell you, when a patient comes, we have to be practical. Somewhere some ultrasound would have been done and they would have found out that query septate are bicarbonate. It could have
Yes.
been, then they would have been evaluated her, is it not? So probably that may not be a cause in this case, is it not? But what I want is, here fetal heart appeared and then disappeared, is it not?
Yes, ma'am.
So what
Yes,
could be
ma'am.
the most probable? Why did we go here? One more investigation in the first trimester pregnancy losses. What is the first investigation people think of?
Endocrine, first trimester of pregnancy loss after presence of cardiac activity, we have to think of antiphospholipid.
Chromosomal
Chromosomal
abnormalities.
abnormalities.
The first thing
Chromo-
people think of.
Yes, ma'am.
Anybody you see when they ask RPL, first thing they ask is for the parent
Chromo-
karyotyping. Suppose I think if this is case, because especially see, APLA, how it happens usually,
There
fetal
will
heart
be
appears
and then disappears.
disappears.
Yes, ma'am.
Then it becomes an immunological problem. Here, see, the fetal heart was there.
Yes,
Is
ma'am.
it not? Fetal heart was
Yes,
there,
ma'am.
but then she bled. But we
Yes,
don't
ma'am.
know whether the in between fetal heart disappeared or not. We don't know about it. Is it not? We have only this much of information. So first thing we have to think of chromosomal abnormalities. If I have to think of chromosomal abnormality, am I right in this case? Number one.
Ma'am, chromosomal
what should I do?
abnormalities usually will not appear before 10 weeks, before the appearance of cardiac activity itself, ma'am. Mostly it will be
Why? Why?
sporadic losses are more.
Yeah, one thing you said.
Sporadic,
What is it?
sporadic
It could
losses
be.
are more.
It could be sporadic.
Sporadic losses.
It
Yes, ma'am.
need
Sporadic
not be
losses.
recurrent, ma. It
Yes,
need
ma'am.
not be recurrent.
Is it not?
The commonest cause of first trimester loss, when you ask it sporadic, you can say it is a chromosomal. But you can't expect that to recur in subsequent pregnancies. That
Pregnancy.
is what madam is asking.
Which pregnancy, which condition it will recur? Which condition the pregnancy losses will recur?
Balanced
Very good.
translocations. ma'am.
Balanced translocation. Both the couple has got a balanced translocation.
Translocation.
Especially if it is 21-21 balanced translocation, 100% downs will occur. Is it not?
Yes, ma'am. Yes,
And
ma'am.
if it's only mother has got a balanced translocation, it is 11%. If paternal balanced translocation, it's 2% recurrence of the
Pregnancy
Down
loss.
syndrome.
Down
Down
syndrome.
syndrome. Is it not? Okay, you know, no, Downs has got, anyway, coming to the chromosomal. Now, in this case, when there is a recurrent, as the number of pregnancy losses increase, the cause being chromosomal abnormality comes down.
Comes down. Yes,
Is it
ma'am.
not?
Yes,
Only in a balanced translocation, if both of them have got the recurrence can occur. Otherwise, it will not occur. Sporadic cases, it will not occur. Now, to know in this case, whether it's a chromosomal abnormality. Okay, now how do we proceed? How do we proceed?
If it is
Even today, everybody does parental karyotyping.
karyotyping.
Please learn, you people learn it. It is not the right thing. It is not recommended. Now, what you do is
Sending the
conceptus
product of
karyotyping
conception
has
first.
to be done.
Yes, ma'am.
Okay.
Product of
And what method you use to do the conceptus karyotyping?
chromosomal, my 24 chromosome microarray is used.
No,
ma'am.
which a microarray you have to
Yes,
do.
ma'am.
Don't do the karyotyping, it's of no use, but because why? Why microarray? Why not the karyotyping?
It has more false negative results. And
See,
the
in a
maternal
conceptus, what should
contamination.
be there?
The
Unbalanced. Is it not?
Yes, ma'am.
See, if the parents have got a balanced karyotyping, the conceptus must have unbalanced.
Unbalanced.
That's why what you do, unbalanced cannot be managed. I mean, unbalanced can be very well diagnosed by microarrays.
Microarray. Yes, ma'am.
Okay, so that's why you have. What is the latest way of doing this chromosomal analysis?
Next generation sequencing, ma'am. That is the
Very good.
latest.
Next generation DNA sequencing is the best. You can find out even the genomic
Genomic
abnormalities,
abnormalities.
genetic, I mean, the gene defects also you can find out. Whereas karyotyping cannot do gene defects, it can be done. Here, the karyotyping is done for the parents because the balanced translocation can be very well diagnosed by karyotyping. So for the parents, you do, if at all it has to be done, you do the karyotyping. Whereas with the conceptors, to know the unbalanced translocations, you have to do microarray. Okay. Okay. Comparative xenomic hybridization, it is called, or it's a microarray.
Microarray.
Now all this can go. Now it comes only the next generation. DNA sequencing is the best now. That can be done for all these cases. Okay. Now the commonest chromosome abnormalities will be which chromosomes?
Chromosome 15.
Commonest is what? The 16 is the commonest, but it is not viable.
Yes, ma'am.
Pregnancy cannot happen with the 16 when there is translocation. Every chromosome can have translocation except chromosome 1. Is it not? Okay. And then translocations, you have got balanced, unbalanced. Balance, you have Robertsonian. Robertsonian can happen only with which chromosomes?
13,
14, 15, 21, 22.
They are acrocentric chromosomes.
Acrocentric chromosomes. Only those chromosomes we can have Robertsonian. Okay, translocation. Otherwise, translocations can happen with anything except the one chromosome. Okay. So the chromosomal analysis, we stand where it's a conceptus karyotyping has to be done. If it is an unbalanced translocation, then the parental karyotyping has to be done. So there is no point in go on doing the parental karyotyping as a first investigation. Today, even today, first investigation is karyotyping of the parents, couple, and then second investigation is starch. Okay, these two to be given, and of course, chromosomal first trimester abortions, losses, we have to think of chromosomal, but this is the way chromosomal analysis has to be done. Conceptus, if it is unbalanced in conceptus, then parental karyotyping. Suppose the parents have got a balanced translocation. Now what will you do? She has got a balanced translocation. Now what is the advice you give to her?
Pre-genetic
yes, you can.
Pre-genetic implantation testing.
But usually what is advised? Because she is going to have an abnormal babies continuously because she has a balanced translocation. So what is advised is donor ovum. Donor ovum has to be advised for her. Yes, these are the cases where pre-genetic, this one has to be done testing. Which are the other conditions where you do the pre-genetic diagnostic?
In case of any inversion, unbalanced translocation, inversions, and pre-genetic testing will be done.
Yeah, parents have balanced translocation and the age about 35 with recurrent pregnancy loss. Okay, these are the things. Not everyone, but you only have to have a specific people. Okay, now go ahead. So in this case, you have done because it's right probably because 3 pregnancy losses have occurred. So you have done the APLA workup. Now, what is APLA? What is APS? And what is obstetric APS?
Obstetric APS is as a APS, a presence of APS, autoimmune systemic disorder, associated with or without pregnancy morbidity, but with no previous thromboembolic.
Obstetric APS. I am asking you definition of obstetric APS.
Obstetric APS, and you're saying no recurrent.
No pregnancy. Without pregnancy, you say no. Obstetric APS is what?
With recurrent pregnancy loss, with pregnancy complications.
No. See, obstetric APS is they have only pregnancy events problem. They don't have any other. That means they don't have any previous history of thromboembolic. Other organs are involved. She is not a hypertensive. She didn't have a stroke. Okay. She doesn't have other problems like, okay, there are many other problems. What are the other problems they can have with the APLA? Antiphospholipid positivity. One is obstetric problems. The main thing is obstetric. Other one is thromboembolic event. What are the other things they can have clinically? Because it is a multi-organ
dysfunction. They can have multi-organ dysfunction.
What are the other things they can have? What are the other?
They can have renal failures, ma'am. They can have heart attacks.
Heart valve defects they can have. Heart valve defects they can have. They can have chorea. Okay, neurological symptoms they can have, and then they can have what else they can have?
Respiratory
problems.
Respiratory
cutaneous problems. What do they have in APLA? That's why whenever you have an APLA patient in general examination, you have to see for all the cutaneous problems. What are the cutaneous problems they can have?
Livido-reticularis.
Libido-reticularis is good. Then gangrene of the fingers
Gangrene
they
of
can
the
have.
fingers.
Okay. They can have rashes they can have on the body, and ulcers they can have because of the block.
Blood supply.
Loss of blood
Peripheral
vessels.
small vessel block, ulcers they can have on the legs or and the hands and all these cutaneous problems they can have, is it not? So you have to think of all, and what are the other things what you can have? The investigation. Suppose I do minimum investigations. Can I be able to find out suspicion? In the case of RPL, I got a routine investigations. In a routine investigation, which investigation will give you the suspicion whether we are dealing with RPL? I mean, APLA, sorry. What are the investigations?
ATP, ma'am, platelet count and
Good. Platelet
ATP.
count, what happens? Thrombocytopenia can be there.
Thrombocytopenia will be there, ma'am.
Unexplained prolongation of the APTT, can be
APTT
there.
will be there.
And VDRL can be positive.
Positive.
And what else can be positive in these people? What other test can be positive in these people? False positivity. What other test?
VDRL.
VDRL we said, yeah. VDRL
Yes,
we said, torch.
Torch infection.
Cytomegalo and toxoplasmosis also can be positive. Okay, these are the things which can be positive in this case. So if the thrombocytopenia is there in a patient with a recurrent pregnancy loss when she comes, of course, we can have pregnancy-induced thrombocytopenia. But when it is persisting, probably she had 2 or 3 losses. First thing you jump and say that it could be an IPLA and work up on that. Okay, that will give you. Okay, so these are the other things what we can have. This is called atypical symptoms and the investigations for APLA. Okay. Yes, go ahead. Yes, ma'am.
Okay, ma'am. After the 3rd miscarriage, patient was evaluated for antiphospholipid antibodies and was found
When
positive.
will be ideal time to evaluate for the APLA? What is the ideal time to evaluate for APLA?
After the 2nd miscarriage, ma'am. Now, after the
No,
2nd
no. See,
miscarriage.
evaluation
After 6
for
weeks.
RPL is after the 2nd miscarriage. That's what
In between pregnancies, ma'am.
Huh?
In between pregnancies, we have to.
Yeah, in between pregnancies, pre-pregnancy evaluation is better. Why? Why pre-pregnancy
Because
evaluation?
pregnancy can cause false positive
Yes,
results.
pregnancy can have the alteration in the antibody titers, is it not?
Yes,
if you deal with these cases, you will be really amused and sometimes you will be confused. Today, APLA is positive. Next pregnancy, when she comes, APLA will not be positive for her. She will be positive for ANA. Okay, these are the cases which I used to deal with, and it's really challenging and amusing to know each time how these autoantibodies behave. Sometimes these autoantibodies may not be there for what you have estimated it is there in this pregnancy. Next pregnancy, some other antibodies may come up. So you have to be very, very careful. You must know this. All this knowledge is very important for us. So during, suppose she has come 3 losses, now she comes with the pregnancy. Should we investigate her for APLA or not?
If she is pregnant.
She's pregnant. So ideally, we said in between pregnancy, we have to investigate for APLA. But she has come during pregnancy now. What should I do?
Yes, ma'am. We have to still investigate for APLA.
You have to still investigate for APLA, is it not?
Yes,
now, according to APLA definition, when do you consider her as APLA?
When there is one pregnancy loss.
No. The antibodies have to be present for.
Present, yes.
You do twice.
Two separate occasions.
12 weeks apart. 12 weeks apart. This lady has come at 8 weeks. You have done. Okay.
Yes,
and she's positive. Now, should we wait for the 12 weeks apart to get the antibody titer again, or you have to start the treatment?
No, ma'am. No, ma'am. We can start the treatment because she is coming with a history of recurrent pregnancy loss.
Good. And so you don't wait for the 12th week. Should I really repeat it at the 12th week? She's poor lady. She's poor lady and lost so many pregnancies and so many doctors, and she spent money. Now she has come to you. Should we really do after 12th week again?
No, ma'am. We need not repeat.
It depends on the clinical situation, what you are dealing with, is it not? If suppose she has come pre-conceptional, yes, I would have waited after that. I asked her not to conceive for 3 months and I repeat it and see. Why? Now again, there is a stringent protocols have come for the heparin therapy in APLA also. So we need to follow that. Not everyone you put it off with the heparin, okay? The latest protocols are very stringent about it. Okay, if the time permits, we'll talk about all those things. So what we need to do is now we will repeat it. See the difference. But when she comes as a pregnancy, with pregnancy and 3 pregnancy losses, we don't wait, but we need to do.
We start treatment again.
Ideally, when would you like to see these ladies for evaluation for recurrent pregnancy loss? During pregnancy or pre-pregnancy?
Pre-pregnancy, ma'am. Ideally,
Why? What is the purpose of seeing
can
them in
start-
pre-pregnancy?
we can start treatment pre-pregnancy itself.
First thing
ma'am.
is
For example,
counseling.
we can, yes, ma'am, we can give
Counseling.
counseling.
Why the counseling?
Because of she
See,
may
I'll
have a
tell you
possibility of
the
recurrence.
psychological problems itself. There's something called at the end tender loving
Tender loving
care.
care. Yes,
Half
ma'am.
an hour lecture I can give on that alone for APLA. It's very, very effective.
Yes,
So the
ma'am.
counseling is very, very important for the patient. That's why you want to see them in the pre-pregnancy, so that they are in a mental status where the anxiety is lessened, so that the conception and the progress of the pregnancy will definitely improve. That's number 1 point. Number 2 point is evaluation is easier for you. Like you said, anatomical, you said something and all. Do we have to do torch in these people now?
No, ma'am, we
No.
need not do, ma'am.
There is somewhere something I'll tell you it has to be done. Okay, I'll tell you that. Let us finish this now. Okay, that's number 1. Number 2, yes, as you said, there are some drugs which you need to give a pre-pregnancy
Yes, ma'am.
in a APLA, is it not?
Yes,
What are
ma'am.
the drugs you give in a pre-pregnancy in RPL cases?
We can start her on low-dose aspirin, ma'am.
When will you start low-dose aspirin in them?
1 month before we're planning conception. ma'am.
1 to 2 months before
1
planning
to
the
2 months
pregnancy.
before planning.
Why do you think you have to give this? Why do you think you need to give the aspirin pre-pregnancy? Why?
It will give it will affect
Yes.
It will.
it,
for
the
good
implantation.
implantation.
Yes, ma'am. For the good angiogenesis and
Huh?
implantation. For that
Implantation.
reason,
Nikita, you also, I would like to listen your voice also. Nikita, please.
Ma'am,
You are
it is,
too silent. I'm very noisy and I don't like silent people, students.
Ma'am, for
especially.
better implantation, ma'am. So,
How does it help, Nikita? Correct.
ma'am,
you
it
are
has antithrombotic. The
Very
main
good.
one is
Platelet
antithrombotic.
aggregation, it will stop, is it not? If you go to the pathophysiology of the APLA, what is the most important factors in pathophysiology at the vascular level? What happens at the vascular level in APLA?
Ma'am, the
Platelet aggregation.
platelet aggregation, ma'am.
Platelet aggregation and endothelial
Endothelial dysfunction.
PG
tissue.
imbalance, prostaglandin imbalance. A2 will be more than IG, is it not? Okay, prostacyclin and thromboxane. Thromboxane will be more, so that again it will encourage vasospasm and the clotting, is it not? So this will be brought down by aspirin. So if there are APLA positive, this process is going on in the body, is it not? It's not only related to obstetrics. So that to prevent that, you start pre-pregnancy aspirin. That's number 1. Number 2, is there a role for
Folic
pre-pregnancy
acid.
heparin in these cases?
Ma'am, only after the cardiac activity is started, we should start the patient.
Okay, no, that statement is not no more there. It is not the cardiac activity. As soon as the pregnancy test is
Pregnancy is
positive, you have to
confirmed.
start. Why we
Okay.
start as soon as the pregnancy test is positive?
Ma'am,
What does heparin do?
ma'am,
That means
It will
I need to
bind
ask you
directly
a
to the
question. What is the
antiphospholipid
pathology
antibody.
of APLA? I think we have only 15 minutes left. Okay. What is the pathophysiology of APLA?
It is
if you
autoimmune
take it-
disorder where antibodies are produced against the phospholipid, ma'am. And
It causes what?
uh,
Phospholipids cause what? These antiphospholipids will cause what?
It will cause
thrombosis.
thrombus formation, ma'am.
Number 1, number 2. No, at the pregnancy,
Inflammatory-
why the pregnancy is withering off?
It will affect
Implantation
the
failure can occur,
Yes, ma'am.
early
It will
pregnancy
affect-
loss can occur. Why? What happens?
It will affect directly the trophoblastic
Trophoblastic.
invasion, proliferation, differentiation,
Good.
and invasion.
And the apoptosis of syncytial trophoblast, it will cause.
Syncytial
Main
trophoblast.
thing is it cause inflammatory
Inflammatory
reaction.
reactions by
Is it
complement.
not? Inflammatory reaction it will cause. And complement cascade will be
Activated.
3 and 5 is
T5.
activated. All these things will be nullified by heparin.
Heparin.
Okay, all these things, whatever we said, this is, and then thrombosis at the placental site. All
Yes,
these things are nullified by the heparin. So when should you give heparin? Tell me then. If
As
you know
soon
the
as she is,
pathophysiology.
as soon as she is
No,
positive.
because we need the
Be positive.
implantation. We need the trophoblastic invasion, is it not?
Yes,
We
ma'am.
need all that. A good anchoring of the trophoblast we need. Good vascularity we need. For all
ma'am.
those things, please remember, you get the pregnancy test done. As soon as it is positive, you tell what I do. I give a prescription in IPL patients when they come pre-pregnancy. I ask them, as soon as you becoming pregnant is not a problem in them. So they become pregnant. As soon as your UPT is positive, take the first dose of heparin and immediately come back to me. And anyway, I would have put them on aspirin, even 3 months, 4 months, if they take also, I have no problem, because APLA, aspirin is the treatment lifelong.
Yes, ma'am.
So you put them on aspirin and say, give the prescription to heparin and say that as soon as pregnancy test is positive, you take that and then come back to me. Otherwise, you miss at that time itself. By the time they come to you, it's a miscarriage. I have seen patients. So that's the way you have to give. So now you learn one more point we learn is take home messages.
Start heparin.
Has to be started as soon as the pregnancy test is positive, not to wait for the cardiac activity. Cardiac activity may not come at all in many cases. It will wither off then and there. So you have to start heparin there. Okay.
Okay, ma'am.
And at the same time, having said that, what we say, unnecessarily empirical heparin treatment should not be given. Okay. Should not be given. Okay, go ahead.
And the pathophysiology of recurrent pregnancy loss in early trimester is different from that occurs after. You are saying before 34 weeks that there is a loss due to preeclampsia or abruptio. That you have to think of thrombosis. In early pregnancy loss, as Madam said, it has got a direct effect on the trophoblast, an inflammatory reaction and a complement activation that you should think of.
And can we stop by giving heparin? She going to get a hypertension because of APLA? Can we stop FGR because of APLA?
No, ma'am.
Those things we may not be able to. We may continue the pregnancy can be continued because of heparin and aspirin, but we are not going to, because it's a pathology, is vasculopathy it is.
Yes,
so she can develop preeclampsia, still she can develop FGR. And she can have abruption also. So throughout pregnancy, we are keeping our fingers crossed in the case of APLA syndrome. Anytime anything can happen, is it not? We can't pat our back saying that, yeah, first time we have crossed, so we won the game. No. Still we can lose. So we have to remember all that. Yes.
Okay.
Now she's a 12th week pregnancy. What all you are going to do? She is positive for what?
8 weeks, ma'am. Anti-cardiolipin and anti-beta glycoprotein 1 antibody.
Oh.
And she
AA is found to be negative. Now, what do you call this? Now, there are APLA syndrome is, what are the types of APLA you have? Quickly. Oh, 10 minutes we have.
Types of.
No, madam, you can take some more time, madam.
How
10
can I
more
take
minutes.
The next session is there for you. Next session is there. Okay. It is high risk APLA, low risk APLA, primary APLA, secondary APLA.
Secondary APLA. Yes, ma'am.
And then congenital and acquired. Acquired is because of?
Tell me, what is a high risk APLA, Shaflia?
High risk APLA is positive lupus anticoagulant test, 2 positive lupus anticoagulant test, or triple positivity, or of either any two, a triple or double of any two antibodies. It could be anti-cardiolipin antibody, lupus anticoagulant, or anti-beta 2 glycoprotein at 2 separate occasions, 12 weeks apart. And low risk patients are in high titer. In high titer,
high titer and persisting titer.
Persistent. That word we need.
What do you mean by
it is a persistent one?
APLA profile, you call it. What is APLA profile? Type of antibody, okay, titer of the antibody and persistence of the antibody. These three things together, we call it as a APLA profile. High risk APLA profile is what you said. Low risk is any one of them.
Low titers.
Could be transitory and low titers, is it not? Titer above 40 is taken as?
High titers.
High titers. Before that, we had a mild, moderate, high titers. Now it's all not there. It's a high titer is as anything above 40 is taken as high titer. Is it not, ma? Okay, now she has got. Why do you want to know this APLA profile? Why should we know about APLA profile?
For the classification, ma'am.
Huh?
For the classification and for assessment of
management. See what happens in a high APLA profile. That means 3 antibodies are positive. In spite of your aspirin, heparin, you will not. The success rate is only about 50 to 60%. Still, 30% of them we lose the pregnancies.
Okay.
Is it not?
Yes,
That's
ma'am.
number one point we need to know about it. And then if there's a high titers, what is the dose of heparin you are going to give for her?
Then we have to give her therapeutic dose of heparin, ma'am.
Therapeutic dose you give, not the prophylactic dose, is it not?
Yes, ma'am.
And one more high profile is any other high risk factors are there. What are the high risk factors associated with this? Now they have given a beautiful protocols for the how you have to, when you have to give heparin, how much you have to give heparin. What is the high risk factors in her? What are the other high risk factors? One is all three antibodies positive, number one in high titer. Second is associated SLE.
SLE, yes,
She
ma'am.
had history of
Thromboembolic
thromboembolic
event.
previously in her. Is
Yes,
it not? These are all the patients who come under high category.
High.
Such patients, you start as heparin at the conception. Suppose she has got only 2, lupus is not there. You start them heparin at 28 weeks. Okay, you can start
Okay.
heparin at 28 weeks of pregnancy and continue. Suppose there's only one antibody is positive, not the lupus. Whenever the lupus is there, you have to have heparin, right?
Heparin.
Only one antibody is positive. Anticoagulation is positive in a considerable amount, titers. Then you don't give, you have to give postpartum heparin for 10
Thromboprophylactic.
days.
Okay.
Okay. In these people, high risk people, you give heparin how long? Throughout pregnancy.
Throughout
Whoever has
pregnancy
got
and
throughout
12
pregnancy, they have to take heparin 6 weeks
6 to 6
postpartum.
postpartum. Yes, ma'am.
So those are all the strict protocols which is given. Okay. Now, usually SLE can be associated with this, is it not? SLE rather can have an APLA also. Such people still problem. Now, what are the other drugs we use for the APLA?
With the other drugs that we
Latest.
can latest are we can use prednisolone, ma'am.
Mhm.
We can use immunoglobulins.
Hmm.
We can use
Hydrochloroquine.
hydroxychloroquine, ma'am. Sorry,
Hydroxychloroquine. Which are the patients whom you are going to put hydroxychloroquine?
In refractory cases, ma'am, where the patient
Shaf-
is not
Refractory
Shafia, what
cases,
is the secondary APLA?
associated with SLE, ma'am. If it is
associated with SLE, you will give, and refractory you give.
hydroxychloroquine.
Okay,
Yes,
in
ma'am.
spite of heparin, therapeutic dose, and aspirin, if pregnancy fails, you are going to give. Associated with the ANA,
Yes,
associated with the lupus is positive. All these people you start hydroxychloroquine. When do you start hydroxychloroquine?
at the when the
Preconceptional. Preconceptional. 2
Okay.
months before conception, you give hydroxychloroquine 200 milligram daily, and then ask them to conceive. Okay.
Okay.
Especially when the lupus is positive and then she has got associated SLE, all these people you have to start. What is the role of immunoglobulin? X-ray says there is no role for immunoglobulin, but immunologists are strongly recommending immunoglobulin in refractory APLA syndromes. Okay, refractory APLA syndrome, they are recommending. Okay.
Okay, ma'am.
Immunoglobulin is coming up in a big way by the immunologist, and now they are treating the APLA syndrome and then they are APS rather, obstetric ABS, and they are putting them immunoglobulin. Okay, what are the latest other drugs which have been on trial for this APLA syndrome? Statins.
Statins, ma'am.
Statins they are giving. Okay, and then rituximab.
Adalimumab and certolizumab.
Okay, they are trying that also in APLA syndrome. Now, go through your case. Another 5 minutes we have. That's all. Unfortunately, go through your case quickly. Yes, go through.
The present pregnancy, she conceived 7 months
No,
after.
the next slide. Next slide. No, we are in the next slide. No, sorry. Yeah.
That was the present pregnancy, ma'am. In
Hmm.
this pregnancy, urine pregnancy test was done at 45
She
days.
was preconceptionally diagnosed to have APLA, is it?
Yes, ma'am. She was.
So what have you done for her at that time?
She was diagnosed from outside, ma'am. When the patient came to us, she was already on low dose aspirin 100 mg. And once we
How
did
much you give low dose aspirin in these patients? How much you have to give?
100 mg, ma'am. The new.
Is it? Okay. Okay. See, because you are starting heparin, you can do 75 milligram of aspirin and the heparin. Okay.
Okay.
Preconceptional, we put 150 milligrams. When she conceives and comes, when you start the heparin, probably along with that 75 we are giving. Okay. Yes.
After that, we did an ultrasound, ma'am. The CRL was corresponding to the period of gestation and cardiac activity was noted. And patient was started on prophylactic dose of unfractionated heparin as she was not affordable for low molecular weight.
Okay. If you start with unfractionated heparin, what are the problems we have?
We have to give her supplemental calcium and vitamin D, ma'am, because there is a chance of osteoporosis and thrombocytopenia with
even for low molecular
weight
that
also.
Minimum it can cause, but it will cause. No, apart from that, thrombocytopenia is the main cause. And when you give the heparin unfractionated, you have to monitor with APGT.
Platelet, yes, ma'am.
Whereas
The
low
compliance is
molecular weight, you
better with
don't
low
need to
molecular
do
weight.
any monitoring for her unless lupus is positive, and where you have to do factor 10A. Is it not? There you have to do.
Yes, ma'am.
Otherwise, usually we don't do for the low molecular weight heparin at all. So that's an advantage. Plus the dose advantage is there. Okay.
Yes, ma'am.
Hmm.
After that, there was no history, past history of any.
Okay, now she has become pregnant and you have started on heparin as well as this. Probably HCQ, whether we needed in this case, I don't know. Now I have no time to discuss all that. Now how will you continue? I mean, how will you monitor this pregnancy? Yes, ma'am. 28-year-old. Yes.
Yes, ma'am. She is a 28-year-old gravida for abortion 3 at 8-week 5-day gestation with recurrent pregnancy loss with antiphospholipid antibody positive, anticardiolipin and anti-beta-2-glycoprotein and high titer. So for this patient, we have already started her on low-dose aspirin and unfractionated heparin, and it will be continued along with vigorous monitoring.
Now, what are the other investigation you would like to do for this patient? Shishi, how much time I have? 1 minute. 1 minute. No?
You have 5 more minutes, ma'am.
5 more minutes, madam.
Okay. Just what are the other investigation you would like to do in this patient as a baseline investigations apart from this?
Her renal function test, ma'am.
Good, very good. Renal function.
Her platelet test that has already been mentioned.
CBC you have to do.
CBC.
Renal function test you have to do, and the LFT you have to do.
LFT.
Because they can go for the help. Thrombocytopenia can be there, help can be there. So for that sake, you have to do all these investigations as a baseline investigation. Now, how do you monitor her? How frequently you have to do scans for her?
She should have scans up at least every 2 weeks, ma'am.
No, 12th week you do scan. After that, 20th
12th week.
you do.
20th week. After
you
that,
have to do at least every
2 weeks.
2 weeks. No need.
Depending on the
See, you
severity.
can do once.
Depending-
Yeah. Frequent
Depending on
scans
the
you can do
severity.
at least, say, after 20th week scan, you can do 24th and then 30 weeks and all.
30.
And okay, that's the way you have to do. And what all you look for in this patient when she comes to you for the antenatal checkup?
We have to look for any aggravation of any new symptoms that she may develop. We have in fetal maternal and fetal, ma'am. In fetal monitoring, we have to look for the Doppler.
Mainly
study.
FGR, yes, Doppler
FGR,
has to be
Doppler
done from
studies has to be
24
done.
weeks onwards. Please be doing Doppler, because whatever it is, there is an insufficiency will be there, placental insufficiency. So Doppler has to be there, and Doppler will decide for us when we are going to deliver.
Yes,
Is it
ma'am.
not? So that is a must for us. Doppler is a must for us. Okay. Yeah. That, and then the frequent visits have to be there. You look for the height of the fundus and then the Leica clinically.
Leica, yes,
And
ma'am.
then these two things which you have to see for the FGR and the oligamnios. These two can happen. Suddenly we may lose the pregnancy. So you have to be very, very cautious. Never relax in this until they deliver. Okay. Okay. Now, when are you going to deliver for this patient? Please stop me when I have to stop. Please.
Yes.
Don't hesitate to stop me. Please stop me when I have
No,
to
ma'am,
stop.
you can
Yes.
continue, ma'am.
You tell me, when will you deliver her?
We will allow her for not. We will allow her to continue her pregnancy for normal delivery only, ma'am. And if everything is well.
Sorry. 38 weeks, everything
38
being normal.
weeks.
She has not become hypertensive. She has not have a FGR. Still you
Still
deliver
we
them
have
at
to deliver.
38. Please. Okay. Don't go beyond that. Don't be greedy to take her to 40 weeks. Never.
Okay.
It used to be 37 weeks. Now we made it at 38 weeks. It has been made now. Not me, of course, the literature says. And we have lost. At term, we have lost few people. Okay. So don't be greedy to take them to the term. There's no point in, because there is a placental insufficiency. Suddenly the IUD may occur when she gets pains. That doesn't mean that you have to do. What is the mode of delivery in them? Mode of delivery.
Ma'am, at 38
Normal
weeks, we can leave for
normal delivery.
Normal, but you can induce labor at 38 weeks if she doesn't have gone into labor. Yes, vaginal delivery you can try. Now, what about she is on aspirin, she's on heparin? How do you
We will
manage?
stop the aspirin at 37 weeks, 36 weeks, ma'am.
37
and,
you can stop. Yes, 37, you can
37
stop,
weeks.
no problem
And
now.
the
Yes.
heparin will be stopped 12 hours.
See, she's on unfractionated heparin. So when do you
12
stop it?
hours before.
24 hours before you have to stop it.
24
Is it
hours,
not? If the low molecular weight heparin,
12 hours before.
12 hours
Your
before you
battery is
stop.
running low, madam.
Now, when will you
Please
restart the
discharge.
heparin and aspirin?
6 hours after the delivery, ma'am. 6 hours after
Normal
the
delivery,
delivery.
6 hours after.
6 hours
Suppose
after.
she's high risk. She had previously thromboembolic phenomena. Now, in the pregnancy, what are the problems apart from FGR and preeclampsia? What are the other problems you can expect in her during pregnancy?
Thromboembolic
phenomena. She can go for
manifestations, ma'am.
TBs, is it not?
Yes, ma'am.
Anywhere she can clot. So
Yes,
you have to be very careful. They are very, very high risk patients. Okay. So
Okay.
now you start, suppose she had a history of thromboembolic. Okay,
Okay.
before. Now she delivered. Now when will you start the heparin for her?
Immediately postpartum.
Half the dose of heparin.
Half the
you
dose of
give
heparin
immediately a postpartum, at that to low molecular weight heparin you give. Okay.
Okay, ma'am.
And then probably after 12 hours, you start the regular dose of
Regular
heparin
dose of
for her
heparin.
with all other precautions. What are the other precautions, postpartum precautions you take in this patient? Hydration, early
Hydration.
ambulation, stockings.
Yes,
Please,
ma'am.
please, every patient you have to say. Tamil Nadu, I don't know whether they drink water, but in Karnataka, they don't drink water postpartum. So you must insist on all those things. Okay.
Okay, ma'am.
How long you give heparin postpartum?
6 weeks, ma'am.
6 weeks we give. Okay. After that, we send them to immunologist. Let them
And
take
then they
over
will
and
take it.
give the aspirin, whatever they want. HCQ, when will you stop? Suppose she's on HCQ. When will you stop?
2 weeks
2 weeks.
before.
No need to stop HCQ at all. Once we have done, and then delivery, after delivery, you ask her to go to the immunologist and find out whether they want to stop or they want to continue for some more time. That's left to them. But we don't
Okay.
need to stop the HCQ.
HCQ.
Okay. Prednisolone, as per, there is no role unless she is positive for ANA.
ANA.
Anti-nuclear antibodies,
Antibodies.
especially low and low. If she's positive, you have to put on prednisolone. Otherwise, we don't give prednisolone, but we add HCQ, which is giving a good results for us. Okay.
Okay.
Immunoglobulin, yes, it is a. What is seronegative APLA? That's the last question, I think. Yes, we can't be going on taking encroaching
False
on others.
positive test for
Seronegative APLA. What is seronegative APLA? She has got a clinical symptoms. All the clinical criteria she fits in, but serologically, when you do
lab
Lab
criteria.
test or not?
lab tests are
Positive.
negative.
Negative.
Lab tests are negative. What do we do in such patients? We say don't give heparin unless it is approved. How do we manage her?
Only low
Seronegative
dose.
We'll put her
Aspirin.
on aspirin alone, ma'am.
You have to do other isotopes of the phospholipase.
Phospholipase.
You have many other phospholipids.
Like
Is it not?
phosphatidylserine and
Serine,
Phosphatidylglycerol.
ethanolamide,
Oh.
inositol. Okay,
Okay.
all these have to be done, and one more is IgA. You have to do. We
Okay.
do only IgG,
Low
IgG,
titers.
but you have
Yes,
to do
ma'am.
IgA also. Okay.
Okay.
Once you do that, if something is positive, now there's a profile in Bangalore city. They do all these 9 antiphospholipids. They do. Any one of them is positive, you are justified in putting a heparin for 12 weeks.
Okay, ma'am.
Other
12
things,
weeks.
only
High
12
risk.
weeks because implantation we want. After that, you continue with the heparin. If it is doubtful, you don't have the facility to get all other things. What I advise is up to 12th week, we give heparin prophylactic dose, not the therapeutic dose. And then you just stop the heparin and continue with the aspirin in seronegative APLA syndromes. Okay.
Okay.
APSs, obstetric APSs,
APS.
only they have obstetric problem. They
Complications.
don't have any other problem. It's a
Thrombotic.
This is a big entity, separate entity, obstetric APS, antiphospholipid syndrome.
Madam, recently they have that FOXL-D gene mutation, which is present in the
Yes.
long arm of chromosome 5. It has
Yes,
been found out that it's present only in patients who have
Obstetric.
got a recurrent pregnancy loss,
yes,
and it is not absent in cases of an RP.
yes. That's
Okay.
why this is
It
a
is due to
separate
a
entity.
genetic mutation which is present in the long arm of chromosome 5.
Yes. And what are the other genetic mutations you will have in these people? Cause for APLA syndrome? What is the cause for APLA?
Prothrombin gene mutation, ma'am. Then
That is
This is, say, HLA D4 and 7
D4,
mutations
okay.
will be there in them. That will be genetically carried in the family. Or
Okay.
mother would have transmitted the autoantibodies to the fetus, conceptors. And those people will become again a APLA positive.
Oh.
APLA positive is not equal to syndrome. Syndrome is when there is a clinical manifestations. APLA positive is only antibodies are there. For that people, you give only aspirin. Non-pregnant also 2 to 5% of them are positive for APLA antibodies. Even you and me, I don't know. If we test, we may be positive.
We may be
But
positive.
we are not exhibiting any problems.
Symptoms.
This is not. Such people only aspirin can be given to prevent the thromboembolic events. But when it becomes a pregnancy, as madam said, it's a specific gene mutation or it's a chromosome 5, okay? There is a problem. Those people only become obstetric
Positive.
APS.
Obstetric
It is now
APS.
separate entity, okay?
Okay.
And thanks a lot.
Madam, the recent
for
drug
this opportunity.
sitagliptin, madam,
Amma?
the recent drug sitagliptin, it is coming in a long way, and they are saying it can be given preconceptionally to
Yeah.
increase the.
Yes. Lot of drugs have been tried, but
madam.
all of them are only on trial. Okay.
Madam. Okay.
And then angiogenesis inhibitors are coming, statins are coming,
Yes.
and then oral anticoagulants. Can we give, where it is the role for warfarin or oral anticoagulants in these cases?
What?
Ma'am, warfarin should
In
not
case
be
there is heparin-induced thrombocytopenia, then we can switch over to oral anticoagulants.
Which oral anticoagulant cannot be given when the APLA3, this ones are positive, antibodies are positive?
warfarin.
Warfarin, ma'am.
No, warfarin you can give. No,
Can
after
give.
first trimester you can give warfarin only.
Non-vitamin
Warfarin
K
you give when there is a thromboembolic event, history of thromboembolic event were there in her past history. Those people will be on warfarin and you continue first trimester.
Do you know any name of a
After that, you
non-vitamin
have to
K
give.
and
You have to give afterwards for them, is it not? So that you keep the INR at 2 to 3 in them, but 2 to 3 we cannot keep with the placental bleed. So you keep it about 2.5 INR we'll keep, and we give aspirin who had a thromboembolic events. Otherwise, you can give even therapeutic dose of heparin, switch over and give therapeutic dose.
and the
we
time
don't-
is over, madam.
Yeah, I know. Thanks a lot. I'm
Thanks,
extremely-
madam. Thanks, madam, for the.
Extremely sorry
Excellent.
for taking 10 minutes. I think
No,
8
madam,
minutes
it's
of
all
time
right.
we have taken.
Thank you, madam.
Okay.
Thank you.